Thank you, Rukshani, and thank you to the Sri Lankan Society of LM for inviting me to your very first webinar. Can I share my screen now? Yeah.
Yes.
Is this fine? Can you see my screen?
Yes.
Yes.
I'm just going to minimize and turn off video so that it's easier. So yeah, thank you once again. It gives me great pleasure to be here and to talk about a subject that, three subjects that I'm passionate about: lifestyle medicine, women's health, and exercise. My disclosure, I have nothing to disclose. I will not be discussing unlabeled or unapproved use of drugs or products. The learning objectives of this talk are to understand what is lifestyle medicine, the pillars of lifestyle medicine, and how do each of these pillars relate to women's health, obstetrics, and gynecology, and how can we use LM in treating women and improving their women's health, and also when to understand when do we refer a patient. I'm calling it women's health because this is not pertaining only to obstetrics and gynecology. As you know, as an OBGYN, you get to see many other problems like back pain, obesity, and so on, which are not necessarily directly related to, or apparently don't seem to be related to, lifestyle medicine. Rukshani has already defined lifestyle medicine. So today I'll give you a bird's eye view of how LM can be leveraged in the context of women's health. And I say bird's eye view because what I've tried to do is to condense the theory of LM and 3 decades of my own clinical practice into a 40-minute talk. So I hope to leave you with some really broad insights. I'll begin by noting the main pillars of LM, which are nutrition, exercise, sleep, stress, relationships, and addictions. Of course, this is not an all-inclusive list and is evolving every day. But if we address these main aspects with every patient that we see, we'll get a better understanding and a more wholesome picture of the patient, or rather the person who has the disease, and not just the disease itself. I'll start with nutrition, which is the first pillar. Nutrition is probably the most controversial aspect to deal with, because as we all know, everyone has an opinion about food because we all eat, and it can be very, very polarized. These opinions about food can be strong and sometimes the basis of controversy. In 2019, the Eat Lancet report came out to address the challenge that is facing all of humanity. The goal was to provide the growing world population with healthy diets from sustainable food systems. So it's not just to address the health of the individual, but the planet as a whole. So while on the other hand, we have an overproduction of food, overindulgence in food, and an obesity epidemic, more than 820 million people still lack sufficient food, and many more consume very low quality diets. So to address this global food as well as planetary crisis, the Eat Lancet Commission convened about 37 leading scientists from 16 countries and various disciplines, including human health, agriculture, political sciences, etc., to develop a global scientific targets for healthy diets. Now, this is to create a pattern of eating that's to be shared worldwide to feed all of the expected 10 billion by 2050 using sustainable food systems. Keeping in mind the environmental impact of the various food systems, most studies have concluded that a diet that is rich primarily in plant-based products with fewer animal sources confer both improved health for the individual and for the environment. So it will be worthwhile for all of you to just read this report, which is easily available online. Now, one of the largest prospective cohort studies, that is the Adventist Health Study 1 and 2, followed the Seventh-day Adventists, which is a group of people who have very similar behaviors, like they consume a plant-based diet, they avoid alcohol, smoking, they're physically active, they prioritize religious beliefs and family connections, and so on. Almost all of the risk factors and diseases are improved when the individuals were 100% plant-based as compared to those who are even lacto-ovo-vegetarian or pescatarian. In the Nurses' Health Study and the Health Professionals Follow-Up Study, which are also prospective studies, It concluded that diets that are low in trans fats, saturated fats, refined carbs, and even sugar-sweetened beverages and that are rich in fruits and vegetables and whole grains and sources of unsaturated fat, these were associated with a lower risk of cardiovascular diseases and an improvement in overall health. The EPIC study concluded that a diet that's rich in antioxidants, again, from fruits, vegetables, etc., provided an overall benefit to human health. So in the light of all these findings, we as LM physicians primarily recommend a plant-centric whole food plant-based diet, which is minimally processed, focused on brightly colored vegetables, fruits, plant proteins from legumes, nuts, seeds, etc., choosing whole grains over refined products, and adding other health-promoting herbs, spices, and keeping the oil to the minimum. Now, women are traditionally the nutritional gatekeepers of the family. By that, I mean the primary responsibility of cooking, shopping, decision-making, etc., for menus, for the food of the children and various other members of the family and extended family usually lies with the woman. Now, this is an enormous responsibility. It's also an enormous window of opportunity for us as OBGYNs and primary health caregivers to coach them in the right direction regarding nutrition. Very often we see that how we eat and how we eat as adults is a reflection of how we are trained to eat in childhood. And the propensity for poor eating and obesity is often established in childhood itself. The influence that women experience from marketing, media, big food companies, and so on are not necessarily all to their benefit. Women are more likely to follow fad diets and experience social pressure to look a certain way, especially when they are younger. Social pressure can be very detrimental. And to add to this, women undergo various physiological changes through their lifespan, as you know, during menarche, pregnancy, post-delivery, breastfeeding, menopause, etc., exposing them to hormonal fluctuations, which also leave them vulnerable to emotional upheavals, which influence food choices. Having a poor body image, which can again begin in childhood, can be a source of many eating disorders that we see in our society, which is very appearance-focused. It's next to impossible not to be influenced by the media images and not become insecure about the way we look. And again, women are influenced to this social pressure. So the concept of dieting itself is a precursor to eating disorders. And 35% of dieters eventually progress to some form of pathological eating disorder or the other. The National Eating Disorder Association claims that these disorders are 4.5 times higher in women than in men. But less than 6% of those with eating disorders are actually considered abnormal according to BMI standards, and therefore they're not even recognized. Having a high degree of awareness about this problem as healthcare professionals will help us ask the right questions to our patients. Now, eating disorders like anorexia, bulimia, etc., are more easily recognized when compared to, let's say, a binge eating disorder, which is not often diagnosed. And then there is the other end of the spectrum, which is orthorexia, which is an extreme preoccupation with healthy eating, where the individual becomes obsessed with healthy food, what to avoid, calories, nutrition, etc. So this becomes a true obsession that's more prevalent among women. And once again, we must be aware and conscious of this. So you may ask, why am I telling you all this? Now, the reason is that nutritional counseling is not simple or straightforward. It can be very difficult and often mired in social constructs, belief systems, deeply entrenched habits and ideologies that are very difficult to overcome. Taking a 24-hour diet recall, for instance, for every patient that walks into our clinic is useful to set the stage for a discussion on food habits. If nothing else, what it does is it enables a patient to actually think about what and how much she eats and opens the door to further discussions. Now, good nutrition supports everything. Take fertility, for example. In PCOS or unexplained infertility, we find high markers of oxidative stress and inflammation. Antioxidant-rich foods like plant proteins, low glycemic index grains and whole grains, B12, folate, omega-3, zinc are important in these conditions. Avoiding unhealthy foods like sweetened beverages, fast foods, trans fats, red meats, all of these things can aid in fertility. The Nurses' Health Study found that replacing animal products with plant proteins instead reduced ovulatory infertility, for instance, for up to 50%. Now, while obesity is a detriment to ovulation and fertility, the other end of the spectrum, where the woman has a very, very low BMI, is also not optimal for ovulation and fertility and conception, and even having a healthy pregnancy. So both ends of the spectrum need to be considered. Now, in pregnancy, the first mandate is adequate nutrition, providing both energy and nutrition for both the pregnant woman as well as a growing fetus. It's well known that healthy nutrition during the peripartum period can prevent birth defects in the neonate. Now, but the newer research suggests that peripartum nutrition, which means how the woman has been eating long before she gets pregnant, and for that matter, even how the man has been eating and how their lifestyle has played out, also modulates the risk for chronic disease later in life for the fetus, which is the basis of DOHAD, or the developmental origin of health and disease. Adequate and ideal nutrition will go a long way to prevent weight gain and to aid adequate weight gain, and will also help the woman lose the excess weight post-delivery. So optimal nutrition is absolutely essential for a healthy pregnancy, and it's an important part of the antenatal checkup, seeing what the woman eats, seeing that she eats healthy while at the same time preventing obesity, which in itself has several complications like your spontaneous abortions, gestational hypertension, preeclampsia, GDM, macrosomia, a higher incidence of operative delivery, and so on. Now, as OBGYNs, we see the patients very regularly over a long period of time, and it gives us enough opportunity to, for instance, reinforce their diet, ask them what the problems that they are facing following a healthy diet, offer alternative solutions, and so on. Now, menopause is yet another time of a woman's life where diet is very critical. Maintaining a food journal to document her eating patterns can be very helpful. Focusing on complex carbs, higher fiber, that is vegetables, fruits, etc., protein intake that's adequate from 0.8 to 2 grams per kg body weight, depending on the woman. Phytoestrogens in flax seeds, chia seeds, legumes, etc. All of those seem to also produce relief from symptoms. You may need to supplement B12, vitamin D, omega-3, calcium, magnesium, phosphorus, and micronutrients. Mediterranean diet, which focuses primarily on plants, is also seems to help with menopausal symptoms. And the main focus of treating a woman in menopause should be to prevent bone loss, build bone, build muscle, prevent fat gain, and maintain energy. Now, in a review article published in the European Journal of OBGYN in 2021, 31 eligible high-quality papers were reviewed. Various forms of phytoestrogens were given in the form of capsules, as well as gels and powders, and it was found that menopausal, urogenital, and other symptoms were relieved. The Women's Study for Alleviating Vasomotor Symptoms, or the WAVE study, which is a RCT, trial of plant-based diets and whole soybeans for postmenopausal women by Bernard et al., found that a combination of low-fat food diet and primarily plant-based and the addition of whole soybeans was associated with the reduction in the frequency and severity of the symptoms like hot flushes, and a general improvement in the quality of vasomotor, psychosocial, and physical and sexual health. Now, many a time we need to work with a nutritionist to initiate and guide women in their diet, because we may need a deeper analysis of her food intake. Her physician recommending and discussing her food with her, however, makes a huge difference, because the importance of her diet sinks in when the physician reviews her food journal, answers queries, and advises her on, let's say, recipes and how to include more veggies, etc. Now, I always talk to my patients about recipes and how to make simple vegetable soups, for instance, and they find it quite interesting. They sometimes come up with their own ideas about including more vegetables and fruits. So it's communication such as this that encourages women to think outside the confines that they're used to. They also learn to look at food differently and be creative in order to improve health. The second pillar of LM is physical exercise. We find that across most countries, women are less active than men. Global average of 31.7% for inactive women and 23.4% for inactive men. Don't miss this opportunity to talk to women about and their daughters about exercise, sports, movement, etc. The physical activity vital signs or PAVs needs to be taken at least during the initial visit, if not every time. Explaining to them that exercise is different from just activity. And even if you exercise for an hour a day, let's say, one needs to stay active through the day because sedentary and sitting is an independent risk factor for ill health. Now, it's important to understand why the woman doesn't exercise if she doesn't. It may be the lack of support from the family, or perhaps lack of self-confidence or knowledge as to what to do, lack of understanding of the importance of exercise, or the lack of opportunity due to environmental and social impediments. Motivational interviewing, which is a very prominent part of lifestyle medicine, is a very important aspect of our regular checkups, because this is where we have the opportunity to help women achieve that behavioral change and move her along the spectrum of this behavioral change module. The universality of sport as an opportunity to challenge its social and cultural norms on a large scale and narrow the gender gap is also extremely important. So encouraging young, mothers and their young daughters, or that is their young girls, to play sport is an important start to encourage physical exercise and activity. Now, we know from literature that there are a huge number of benefits for exercise. I won't go through all of them. We all know the many benefits. Weight loss is only a bonus, but very often a woman starts exercising for weight loss, and this is a great starting point. But along the way, they should also be pointed in the direction of the other benefits of exercise, including the benefit for the brain, better mood, positivity and optimism, resilience to stress, and so on. Reduction in anxiety, depression is also important. And one of the very important benefits is as an adjunct to the management of depression, because you may still be required to continue medication and psychotherapy, but along with that, adding exercise is a very great benefit. In a very large meta-analysis by Schutz et al., 25 RCTs were included comparing exercise versus control groups, and it was found that overall adding exercise had a huge significance on the effect of depression, minimizing depression. So let's start them young, because as OBGYNs, we often see teenagers also when the mothers bring them to us for various other issues. When they come to you with problems like during menarche, take the opportunity to talk to them about the importance of exercise, diet, and other pillars of LM. Their mothers may bring to you because they have PCOD. In these cases, I always try to include the mother and the daughter in the treatment of the plan by encouraging them to, let's say, exercise together, include the family in the dietary changes, and so on. Including exercise for adolescent girls is also very important, because we know that an increase in BMI leads to early onset of menarche, menstrual disorders, mental health problems, poor self-esteem, self-confidence, and so on. Typically, boys are more physically active than girls. So we need to encourage physical activity in girls. Physical activity does increase the biopsychosocial well-being in young girls. At the same time, we need to also be aware of the female athlete's triad, which can occur when the child or the young woman exercises too much or eats too little and drops the BMI to a very unhealthy level, leading to either hypomenorrhea or amenorrhea, a very low BMI, an energy deficit, and often osteopenia or osteoporosis and eating disorders. Now, the WHO recommendation is 150 to 300 minutes per week of moderate aerobic activity, or 75 minutes of vigorous activity, and including 2 to 3 days of strength training, either own body weight or external weights, including flexibility and moving more. So the WHO clearly differentiates the various pillars of fitness. So it's not sufficient to just say, go for a walk. We do need to emphasize that strength training, flexibility, etc., and also including other minor pillars of fitness like speed, agility, reaction time. All of that also becomes important. Now, in pregnancy, benefits of exercise are several, including the prevention of excess weight gain and improvement of mood. There are, of course, recommendations and precautions that need to be taken during pregnancy. Certain exercises like the high impact activities, horseback riding, contact sports, etc., definitely need to be avoided. Importance of exercise in pregnancy should be stressed by the OBGYN. We know that the emphasis by the healthcare professional makes a huge difference to the woman, especially if she has misgivings and the advice that she gets from her elders or from family and peers is rather ambiguous regarding exercise. And we know that especially in Asian countries, this is hugely prevalent. In the postpartum period, it's another important aspect in a woman's life, and it needs guidance from her OBGYN. Recommendations to start exercise can be varied depending upon the mode of delivery. According to ACOG guidelines, she can start as soon as she's comfortable if it's a normal vaginal delivery, but wait about 6 weeks after an operative delivery. Aerobic exercise, strength training, especially to correct the muscle imbalances that she may have developed during the growing pregnancy. Pelvic floor strengthening exercises like Kegels, etc., should be advised. There are many benefits of starting exercise in the early postpartum, including excessive weight gain, helping in the reduction of weight, and also improving mood and helping her to cope with the rather difficult time in the postpartum period. So we're faced with a new set of problems in the postpartum period, and they're all interrelated. Being overweight or obese in pregnancy, for instance, makes it more difficult for the woman to lose the weight post-delivery and sets her up for poor body image issues and depression. Some socio-demographic factors are known to be associated with postpartum weight reduction, including maternal age under 20 or over 40. Primiparity, certain ethnicity like African and Asian, unemployment, low income, low education, smoking, smoking cessation during pregnancy or early postpartum, all will lead to difficulty in weight loss. Now, for effective postpartum weight loss, diet and physical activity combined is better than just diet or activity alone. So we do need to understand that recommending both exercise as well as a healthy diet becomes very important for the patient. We know that postpartum depression is much more common than we think, and it often goes unaddressed. Postpartum depression is known to affect the woman's ability to, let's say, bond with the baby and even breastfeed. Poor sleep in the postpartum period is also connected to the difficulty in losing weight and is connected with postpartum depression. Losing weight is also important to prevent late onset of diabetes, mellitus, especially in a woman who already had GDM in her pregnancy. So while there are several benefits of exercise and healthy eating in pregnancy and postpartum, we need to keep in mind the biopsychosocial aspect of pregnancy and postpartum, especially in the Eastern culture, where advice from other people often plays a very important role for the woman. So tread carefully. In my career as an OBGYN, I've spent many years convincing patients and mothers and grandmothers, for instance, that giving the postpartum woman beans and legumes is good for her and also a good source of protein, because there's a misconception that this may cause bloating and bloating for the baby. In order to be able to change behavior, we need to be able to transfer information in a very gentle and effective manner and not to cause guilt or opposition from the patient or her family. The importance of exercise in the older woman, that is in menopause, is particularly in building muscle and staying strong, and this cannot be underestimated. Muscle and bone mineral density loss is of particular importance for women in the menopausal age group. As the estrogen levels drop around menopause, both bone mineral density and muscle mass and strength tend to decline, leading to falls, injury, and therefore morbidity, mortality, and so on. Strength training that starts well before menopause to build a good repertoire of muscle mass and bone mineral density is really important to prevent sarcopenia and osteoporosis. So we need to understand that Strength training is something that we need to stress for a woman at this age. Mostly they focus on cardio and maybe some amount of yoga, which definitely improves flexibility and can improve strength to some degree. But we see that with strength training, there is a 1 to 3% increase in BMD. There is a reduction in many things like low back pain and pain from arthritis and fibromyalgia. There is an improvement in posture, improvement in self-esteem, self-confidence, and definitely an improvement in brain health and cognition. The third pillar is sleep. And we find that once again, women may be more affected by sleep disorders. Sleep and the lack of it plays a very important influence on the woman, and it influences her differently at different stages in her life, right from menarche to menopause. Hormonal fluctuations seem to play a role in sleep, lack of sleep, quality of sleep, disruption of sleep, etc. According to this very critical review of the connection between pain and sleep by Finan et al., they found in a longitudinal study that assessing the sleep both subjectively and objectively, they found that sleep impairment is a strong predictor of pain, and pain is a predictor of sleep impairment. So it's bidirectional. Now, this needs to be kept in mind when treating women with, let's say, dysmenorrhea or pain from endometriosis or any other painful condition. Asking a simple question like, is your sleep habit, is it disrupted? Do you wake up in the night from a disturbed sleep? Will help you understand that the degree of the problem. So other things like your caregiving demands, most women have extreme caregiving demands, symptoms of menopause like the hot flushes, etc., and even nutritional deficiencies like, for instance, which may cause restless leg syndrome, can also disrupt sleep, and this also needs to be kept in mind. So sleep can affect literally everything. It's associated with women in PCOS because the elevated testosterone, sometimes sleep apnea, elevated stress levels, and the oxidative stress and inflammation that we see in PCOS, the problem of insulin resistant and the sympathetic activation, all of these seem to disrupt sleep. Postpartum sleep disruption as a result of breastfeeding or a fussy baby can be a real problem and cause a very low mood and energy and even depression, postpartum depression. The inability to lose the postpartum weight in the mother is related to her quality and quantity of sleep. Think about it. If you are sleep deprived, you're hardly able to make good food choices or even be motivated to exercise. Pain is a significant disruptor of sleep, as we've already said. So if the patient tells you that her dysmenorrhea, for instance, is disrupting sleep, you need to take that very seriously. Now, stress is another very obvious and significant cause of poor sleep. Anxiety, depression, ruminating thoughts as we try to sleep can be detrimental in both falling asleep and staying asleep. Now, here CBT can be very useful. Cognitive behavioral therapy, which is also part of lifestyle medicine, can be very useful in the management of sleep disorders due to stress and anxiety. Now, with advancing pregnancy, as we know, women find it very difficult to stay asleep or even fall asleep. Growing uterus can cause discomfort and or pain. So we need to address that and ask her about her sleeping habits as her pregnancy grows. Importance of a sleep history, therefore, cannot be overemphasized. And it will not only give you an insight into the degree of the problem, but also with the solution when addressed with the other complaints that she comes with. So we do have many ways to improve sleep, and the main discipline is to practice what we call a sleep hygiene. Many things like a disciplined approach to sleep, prioritizing sleep, and making the woman aware of the importance of sleep, cutting off screen time, practicing mindfulness meditation, yoga nidra, meditation, CBT and stress management are very useful in sleep. Regular exercise, especially when it's done earlier in the day, eating at least 2 hours before falling asleep, avoiding alcohol, early morning light, exposure to early morning light about an hour after waking up appears to set the circadian rhythm for a good night's sleep. So once again, the importance of sleep counseling and a good sleep history should never be underestimated. Educating the woman on importance and helping her prioritize it should be a part of every OBGYN consult. So the fourth pillar is stress. And stress can be defined, as we know, as an individual's response to real or perceived stressor, and involves both physiological and psychological components. There are different types of stress, according to Hans Sale, who was one of the very first researchers on stress. We have eustress, which is positive stress that motivates the individual and helps us move forward, whereas distress, on the other hand, is negative stress, and it's associated with anxiety, depression, poor performance, and so on, and can have a deleterious effect on physical health. We need to differentiate between the two, and we need to also understand that very often chronic stress is not addressed, and this chronic stress, which goes on for a long time, can dysregulate the internal milieu of the body, predisposing her to physical and psychological ill health with long-lasting epigenetic effects. Women seem to be more vulnerable to stress, and they're more vulnerable in times of hormonal upheavals like menarche, pregnancy, postpartum, menopause, etc. And even positive life experiences like marriage, pregnancy, childbirth can be very stressful. And this needs to be kept in mind. Women often shoulder the burden of managing both home and career in the midst of social pressure, so then she's exposed to a higher level of stress. Many often undetected causes of stress can lead to the development of chronic stress. So chronic stress causes several epigenetic changes and dysregulation of normal, let's say even the glucocorticoid feedback, that can lead to increased blood sugars, accumulation of fat inside the cells, and even the breakdown of muscle and bone and the atrophy of neurons in areas of the brain like the hippocampus, which is a memory area of the brain, and the prefrontal cortex, which is which controls executive function. So it does affect the brain. There may be increased blood clotting, atherosclerosis, CVD, and so on. So it can lead to obesity, type 2 diabetes, depression, anxiety, hypertension, chronic pain, autoimmune disorders, various addictions, and so on. In this paper, the authors looked at whether the synergistic combination of highly palatable foods, like that is foods with high sugar and fat, and stress was associated with an elevated metabolic risk. And they showed that the combination of chronic stress and a highly palatable diet is a more potent driver of abdominal and visceral adiposity. So in other words, what it means is that somebody who eats highly palatable food may not necessarily accumulate fat as much as somebody who eats highly palatable food but is also exposed to chronic stress. So that needs to be addressed, and we need to address the stress in addition to her poor eating habits. We know that infertility causes stress and anxiety. So now we need to understand whether the reverse is true as well. That is, does stress and anxiety cause infertility? So that's a little less clear. But in this beautiful paper by Rooney et al., they looked at the connection between stress and infertility. And it's been shown, for instance, that the more depressed the infertile woman, the less likely she is not only to start the treatment for infertility, but also to continue the treatment for infertility. And other studies have investigated the relationship between the ART and the psychosocial symptoms. And they found that women with high stress levels are unlikely to continue management. And there may be and there are also some conflicting results with the pregnancy rates that result from ART. And the reasons for this may be that the women may not accurately report their levels of stress on questionnaires. So we need to keep in mind that while infertility does cause stress itself can lead to infertility and suboptimal fertility levels. Medication that is used to treat infertility can lead to psychological symptoms. The gonadotropins, estrogens, all of that can lead to psychological symptoms, and that can lead to poor mood, depression, and so on. So this can eventually lead to discontinuation of treatment. It can affect treatment outcomes, and it can also be, like I said, lead to suboptimal fertility or even infertility. Now, when we talk about coping with stress, there is a limitation to the management of stress using pharmacological treatment. So while it may be required, and nowhere in lifestyle medicine do we say that we need to remove all pharmacological medication altogether, we need to add other modalities and help the woman manage stress with better ways like meditation, MBSR or mindfulness-based stress reduction, gratitude, journaling, etc., which are parts of forms of positive psychology interventions. Exercise, as I've already mentioned, definitely elevates mood by increasing the endocannabinoids in the brain and by increasing the brain-derived neurotrophic factors. Dance, music, hobbies, talk therapy, counseling, all of these things can be included in the management of stress, helping the woman cope with any stressful situation, especially if it is chronic in nature. Now, the fifth pillar of social connection, fifth pillar of LM is social connections. In fact, this may be one of the most important determinants of health and well-being. And we know this from very long-standing studies like the study of adult development from Harvard. We know that being isolated and lacking in social support appears to determine poorer health outcomes in different diseases, even like remission of cancer, autoimmune diseases, cardiac health, preventing and managing mental disorders, and even in the success and treatment of infertility. Now, humans, as we know, are social beings. We need social connections. So being isolated and being lonely appears to be a huge detriment to our well-being. Having close connections appears to enhance what we call as the relaxation response. It improves mood and improves mental health. It lowers inflammation and produces what Barbara Fredrickson, who's a pioneer in positive psychology, calls positive resonance, which is the type of interpersonal connection that's characterized by shared positivity, mutual care and concern, and behavioral and biological synchrony. So this perceived positivity resonance is hypothesized to be associated with well-being and needs to be encouraged. So asking questions about a woman's social connections, who does she live with? What is her relationship like with her husband or with her children or with her in-laws? Also becomes a very important part of our review with patients, because this really determines her internal milieu and her ability to stay healthy and recover from, let's say, a stressful situation, improve her resilience, and improve both physical and mental well-being. Julianne Holt-Lunstead, who's a pioneer in loneliness and social connectedness, says that there's a robust evidence that social isolation and loneliness increases the risk of premature mortality, and social connectedness reduces this risk. Both social isolation and loneliness are associated with an increased morbidity and dysregulation of various biomarkers of health, like inflammation. Now, researchers in the past have found that those with moderate or low social integration were almost twice as likely to be readmitted in the hospital post, let's say, a myocardial infarction than those with better social integration. Now, specific to women's health, many studies have demonstrated that the importance of social support. Breast cancer is one of the most common types of cancers affecting women, for instance. Now, in this study by Adam et al., the impact of social support on the management of breast cancer was evaluated, and those who received support, the prognosis and general quality of life appears to be promising and well adjusted than those who reported not having received any form of support. In another study by Rosella et al. From the University of Denmark to examine the psychological impact of group-oriented approach to disease management and health behavior in women with PCOS, they found that a combination of group exercise and group counseling sessions seemed to work very well. And in times of in many times in clinical settings, when you talk to the family members of patients with PCOS, you'll find that they say that patient is often socially isolated or withdrawn, with low mood, often expressing bouts of anger and so on. And these women can be greatly helped with counseling and CBT, and also with group therapy. Because when they associate with other patients with a similar problem, there seems to be a lowering of the stress levels and a lowering of the tendency to feel isolated or lonely. One of the reasons that shared medical appointments, which is often practiced with lifestyle medicine, works so well when facilitated correctly, is that women really benefit from connections with other women, especially when they face similar health situations. They feel validated, they feel not alone, their shame and their tendency to feel guilt is lowered, and they feel a better sense of connection with other people, which is very important for their health. The last pillar is addictions. Now, besides the usual suspects of addiction like your alcohol, tobacco, drugs, etc., we need to keep in mind that there are other forms of addictive behavior. Let's say around food. Food addiction is a real thing. Addiction to social media, fear of missing out. All of these can be addictive behaviors, and these can actually reduce the quality of life. And these can be equally, if not more problematic, simply because they're not even considered to be a problem in today's world. And I've already touched upon eating disorders, especially that are especially prevalent in women, and these need to be kept in mind while history taking. Food addiction should be considered. Taking a proper diet recall, as I've already said, talking to women with an open-minded and non-judgmental way is also very, very important when you're thinking about addiction, because we know that addiction is often connected with shame and guilt, and many times is not revealed by the patient and should be gleaned from leading questions and from gentle conversations. You may need the help of a qualified psychologist in this area if you suspect an addiction. Food, for instance, is not always used only to assuage physical hunger. It may be used for various other reasons like boredom, fatigue, anger, anxiety, and so on. Social media addiction is also, as we know, a real problem these days, especially with young women, young people, and it's been shown to cause depression, low self-worth, not to mention the compromise on sleep and productivity. So a very careful history-taking and specific questions about screen time. When do you turn off your phone? What time do you sleep? All of this may be required in order to identify these kind of behaviors. So let's take polycystic ovaries, for instance. This is a condition, as we know, of insulin resistance. Now, besides her regular hormonal workup, like a look at the inflammatory markers like the high sensitivity CRP and insulin-like growth factor, etc., her blood sugars, like her HbA1c, all of that needs to be worked up. Her BMI, fat percentage, etc., also needs to be assessed. But we also need to look at other things, look at her mood. Does she suffer from depression and anxiety, making it even more difficult for her to follow through with advice about diet and exercise? We need to explore her addictive behaviors, whether there is a food addiction or an addiction to, like I said, social media, gadget addiction, etc. Exploring the depth and quality of her relationships and her social contacts is also very, very important. What kind of support system does she have? Does she, like an over-anxious mother, can actually cause more stress to a young girl who's already suffering from mood-related issues? Her stress levels may be elevated, along with poor body image issues and low self-esteem. She may require time with a therapist who needs to look at her very, very holistically. And this is why collaborating with a psychologist, nutritionist, etc., with the LM physician is also very, very useful. Managing stress, screen time, sleep should be a major part of her treatment protocol. There's mounting evidence, for example, for the association of PCOS and sleep disturbances. So now this is very complex and bidirectional. It's not simply due to the tendency of women with PCOS to be obese that is associated with poor sleep. So it's not just the obese women who have PCOS who are seen to have sleep disorders. Even lean PCOS women seem to have a disruption in their sleep. So this suggests that poor sleep is actually a part of the whole pathophysiology of PCOS, because PCOS is a condition of a very severe metabolic stress that cascades into various other things like oxidative and emotional stress. In pregnancy, diet and exercise obviously are very, very important. Proper guidance from an OBGYN goes a long way to mitigate many of the ambiguity that the patient may feel. Be aware that the women who are pregnant can also be very stressed for various reasons. Address her stress and advise stress relieving techniques. Encourage the relaxation response like meditation, yoga, massage, and so on. A strong support system is enormously beneficial for a woman who's pregnant. Often she may not have one. On the other hand, she may be living in a toxic environment with unhealthy and dysfunctional relationships with her husband or with her other children or with her extended family, which can affect her mood, stress, eating, and ultimately her pregnancy itself. Address this using discretion and sensitivity and offer her the support as and when required. Perhaps group consults can help. That is the shared medical appointments with other pregnant women, talking to other pregnant women where she doesn't feel isolated, and also clarify her doubts in a group setting can be very helpful. Offer her a list of evidence-based resources, website links, organizations which can be of support, support groups, etc., can also be very, very useful. Endometriosis, which is a very, very complex disorder. It's a chronic inflammatory disease, often of unknown etiology, where we say that we don't know the cause of endometriosis, and it's very little curative treatment is available. It's very frustrating both for the patient as well as her healthcare giver. Now, our role in the management while reducing pain and treating infertility should also be to improve quality of life for the individual. Reducing inflammation using an anti-inflammatory diet, antioxidants, polyphenols, fiber, micronutrients that are present in high fiber and a diet high in fruits and vegetables and minimally processed foods and plant products is helpful. Now, there's also evidence that a diet that is low in the food map diet, that is fermentable, oligo di and monosaccharides and polyols diet, or higher in omega-3s, vitamin C, D, and E supplements to successfully reduce the symptoms that the patients may be experiencing, help both endometriosis as well as irritable bowel syndrome, which actually can coexist. Stress causes the inflammatory response, as we've already mentioned. So stress reduction protocols are very, very important, and they can be a cornerstone for any disorder, especially when there is pain involved, because pain and stress are bidirectional. Sleep and stress and pain are bidirectional, multidirectional. And I've also had several patients with endometriosis who've been hugely helped when they are not only advised the various stress relieving techniques, but also are taken off animal products completely. This appears to help them in my experience. And they also started on gentle exercises and taught meditation. CBT is also very important in the management of the disease, especially in pain management. So when do we actually refer a patient? As I said, LM is a collaborative practice. It's not something that one does alone. We do need the treating physician who may be a specialist. You may get referred a patient from, let's say, an endocrinologist or a dermatologist for a patient who's suffering from severe psoriasis, and so on. So the treating physician needs to be kept in the loop. You may need to refer to a dietitian and nutritionist for a more in-depth nutritional analysis than what we can do as purely LM physicians. Exercise physiologist, a trainer for fitness to guide her through her fitness routines. Especially in the initial stages, it would be highly beneficial for her to be guided through exercises in order not to injure herself, in order for her to stay motivated. So a trainer or an exercise physiologist is very useful. in order to address her psychological issues, her stress. CBT, cognitive behavioral therapy, biopsychologist, certified psychologist is also very useful. Sometimes she can have childhood trauma, childhood issues that invariably play out in adulthood, and all of these can be addressed, although they can be diagnosed, or they can be picked up in your clinical evaluation when you talk to patients about their past. Things like this need to be addressed by a psychologist, by a qualified psychologist, because they can be way beyond the ability of an LN physician to address. Yoga, meditation, of course, you do need a certified and qualified person to take them through yoga routines, teach them meditation, after which they can actually, they will actually be able to use it to their benefit on their own. So on a final note, our medical textbooks, in fact, even the lifestyle medicine textbooks, are really not sufficient to give you all the skills and tools that you actually require to practice holistic medicine. Practice medicine where you look at the whole person. What is required is practice, practice, and more practice. And you'll understand that as you see more patients and as you come across different kinds of presentations of the patient, using all the pillars, some more than others, understanding which pillar to address first, all of this comes with practice. Now, Obs&Gyn provides an excellent opportunity to engage with patients in the long term, because they come to you in their pregnancy over a period of 9 months. And in the postpartum, for instance, they come for regular checkups, and each review is a window of opportunity to nudge the patient along in the right direction. Even when the patients are apparently cured of the symptoms for which they came, maybe they came for DUB or menorrhagia or dysmenorrhea, and they may be treated with hormones and painkillers in the short term. Ask her to come back for a review to discuss further prevention, weight loss, stress and sleep management, and so on. Most often patients do comply, although some do fall through the cracks because all they want is symptomatic management. But nevertheless, always schedule reviews and reassess the various other pillars of LM so you can address them accordingly. Recognize the interconnections of the human body, of the mind, the body, and the enormous influence that our lifestyle can have on health, your body, and your mind. Read as much as possible. Don't stick with just medical books. Read widely. Read other books on philosophy. Read other books. Like some of my favorite books are certainly not the ones that come from the medical field, but have helped me understand patients way beyond their physicality and their symptoms. So you need to keep reading widely, and that's very helpful. Use various online resources, screening tools, technology. Technology is widely used to assist both in the treatment as well as in the follow-up and tracking the patient's progress. History taking is paramount. We need to take a good history, and we know this. We know this from medical college days, but I think in lifestyle medicine, the history taking is actually very, very extensive. So you may need to schedule a much longer initial interview. Recommend reviews. Some patients may come back, some may not, but do recommend them and schedule them into your calendar. Be open-minded to the different ways of relieving distress for a patient. Meet them where they are. They may not be able to change behavior immediately or at the rate at which you envision or expect them to, because behavioral change is difficult and it takes time. So be non-judgmental about it. Talk to patients gently about behavioral change. Various methods of management in lifestyle medicine, like motivational interviewing, various positive psychology interventions like using gratitude, journaling, using various other modalities from positive psychology, like your strengths, etc., and cognitive behavioral therapy should be used whenever and wherever possible to change the mindset of the woman, not just treat symptoms. So with this, I hope that I have given you just a very brief overview of what can be achieved using lifestyle medicine. Like I said, it's just an overview because it's very difficult to touch upon everything, but I hope it's helped you understand the complex ways in which women can present and how they need to be treated. I'm open to questions if you have any, or discussions and comments.